have talked about health equity quartile. And for the health equity quartile, the percentage is 48% have received at least one dose. Over the past weeks, we've been working really hard with community-based agencies to be able to set up vaccination pop-up clinics in the underserved communities. So that has borne some fruit as we've seen the vaccination rates increase in those areas. Switching now to the questions we've been asked. June 15th is coming up, and that is, sorry, just a minute. And that will be the date that the state will end the blueprint. At that time, the state health officer order will end, and the county health officer order will end as well. Along with that, the guidance that we've been following for the different business sectors will end as well. That will mean that there will no longer be any capacity limits for any of the businesses, and no businesses will have restrictions in as far as whether they can operate indoors or outdoors. What will remain is guidance from the state for face coverings. And what we have right now is that for people who are vaccinated, they will be allowed to not wear face coverings or masks indoors or outdoors, except in certain settings such as healthcare facilities, in jails, in schools, and for public transportation. In addition to that, the Cal OSHA, they're still in the process of updating their guidelines. And so we will be looking at waiting for those guidelines that will determine what people will be able to do in people will be able to do in the settings, workplace settings. I also wanted to talk a little bit about the VAERS system. We have received some questions lately about the VAERS system and the number of cases that are reported in that system. VAERS stands for Vaccine Adverse Events Reporting System. This is a nationwide system that is monitored by the CDC and the FDA. And the reason it was set up is to be an early warning system for being able to see if there are any adverse events that might be linked to vaccines. There are some caveats that people need to be aware of, in that healthcare providers are required to report any adverse events in the VAERS system, but anybody can report. That means patients can report as well, parents can report as well. And so there are advantages to this in that, one, it is a national system, two, it can be an early warning sign, and three, it is the data in that system is readily available to the public. But people do need to be aware that the information in there is not verified. And so sometimes you will see an increase in reports, especially based on media interest and increased awareness in the public. One thing that people also need to remember, because that information is not verified, is that it is not easy to determine if a certain adverse event was actually linked to the vaccine or was just an event that happened to occur after a vaccination was given. So you cannot use the information in the VAERS system to determine the adverse events that are linked to a vaccine. In order to do that, the CDC and the FDA need to go through the information and review it, review medical records, and then be able to make a determination if a certain event is linked or could be linked to a certain vaccine. And I think we saw that in action with the Johnson & Johnson, when we were notified that a certain number of cases were of blood clots were linked to, possibly linked to the Johnson & Johnson. And so the CDC pulled information and did a review to make a determination if there was a possible link and also whether it was safe enough for us to continue using the Johnson & Johnson. And with that, I will turn it over to Dr. Cohen.
Thanks, Dr. Kasirye, and thanks again for everybody inviting me. Just to introduce myself, I'm the Chief of Infectious Diseases over across the street at UC Davis. And we have been seeing patients with COVID-19 since late February 2020. And so it's getting pretty long for everybody. In healthcare, I think we're all feeling like we'd like to see things go away faster than they're going away. But our case numbers are finally starting to creep down. We had been stuck on a plateau for probably a month to 6 weeks with a very similar number of people. And now we're sort of creeping down. The number of active COVID-19 patients are now down into the single digits. And there are about 3 times as many total that are hospitalized at various stages of recovery who are no longer considered infectious. And our infection rate, as far as test positivity rate, is down on average around 2%. Yesterday it was 1.5%, some days a little bit higher. So the numbers are better and as good as they've been almost since the beginning. And so I'm feeling very optimistic. We're also figuring out, similar to the kinds of things that Dr. Kasirye was talking about for the community, we're also figuring out how to integrate vaccine and testing and mask wearing and things like that within a healthcare setting, with the idea that we're going to be probably, well, not even probably, we will definitely be more cautious than in the community, because we will know that there are also people within our facility who either can't be vaccinated or don't get good responses to vaccines. And we also know that there are going to be cases that are going to break through. I think the CDC has reported them. I don't think anyone should be surprised when somebody says a vaccine's 95% effective. That means there are 5% that still get infected. And so it's not 100%, it's not a total blanket. And so we have to be still cautious, particularly around our highest risk people within the population. I think that's the really conservative strategy that we're trying to take. I think similar to the way that the health department is working, and I think a lot of what we try to get done at these community forums is trying to get people enthusiastic about getting vaccinated if they have not been vaccinated, and trying to address people's concerns about these vaccines, because that's still the ticket to finally getting things under total control. And I will stop at this point, and we will move on with our program. Thank you.
Sounds great. Thank you both for your complimentary perspectives. It's great to hear from you, and I know the community's tuning in. Let's get into the questions. And just as a reminder, folks can go ahead and put questions in through the Q&A chat feature, which is 2 little chat bubbles at the bottom of your screen. Okay, have you found any variants of COVID-19 in Sacramento County?
I can start. Yes, we do get reports of variants, and we actually do have that reported on our dashboard under the lab tab. if you get to our dashboard, you will be able to see the reports of the number of variants that have been reported.
Got it. And there's a specific question about the Delta mutation that's been identified in California. Do we know how this might impact Sacramento County as Sacramento County begins to move forward?
I think Dr. Cohen was going to say something, so I'll let him say something first.
Yeah, I was just going to say, I think that one of the things that has occurred since the last time we met is the World Health Organization has defined a new way to define all these variants to try to take the countries out of it and to try to take all those big numbers out of it as part of the way that we communicate. So for those who are not familiar, the Delta variant is the variant that initially started in India and is now the predominant variant in Great Britain. And it is what was initially called a double mutant virus because there are two specific mutations in the virus. One that decreases the effect of antibodies slightly, and I think that that is a key point, that it's a slight decrease. And number two, it increases the transmissibility. So it's more contagious and it will spread more rapidly. There are not a ton of clinical data yet as to how effective the vaccines are in actual patients. But what we do know is that when you measure antibody levels in patients who have been vaccinated and compare the antibody levels to the different variants, the Delta variant, the antibody levels are probably about a third lower than they are with the variants that the vaccine was targeted against, or the so-called Alpha variant, which is the one that is still the predominant variant in California, which is the one that started in Great Britain. I hate to keep having to say those things back and forth. But that, so it may impact it some. I don't think there's any evidence that the clinical effectiveness of the vaccine is going to be less. And moreover, as far as severe illness, I think they will be near equally, if not equally, efficacious.
I think I also wanted to remind us all that that's why it is so important for us to continue the push to get people vaccinated. Even though our vaccination rates have improved, and at least for those that have received at least one dose, we have gone above the 50% mark. But I think scientifically, we all agree that if we can get to 70%, that will give us a much higher level of comfort in knowing that the communities are protected. And then, of course, also there is still some concern about the underserved communities where the vaccination rates are lower. Because as we know, the more people that are susceptible, the higher the chances of transmission. And every time you have transmission, there is a higher chance of mutations. So it's still very important, even after June 15th, to remind people that even though California is doing better, we're opening up, it's not the end of the pandemic. We still have the pandemic. We still have a lot of people that are not vaccinated. And so that's part of the reason why we also still need to have masking mandates in some of the areas, especially, as Dr. Cohen pointed out, in those settings where we have either a large number of people that are not vaccinated or people that are vulnerable.
Thanks, Dr. K. So building off of that last point you were talking about in terms of the importance of masking, Holly has a question. Will there be mask restrictions in shelters and cooling centers after June 15th? Holly said that you listed healthcare, jails, schools, and public transit, but was interested in some of these other types of settings.
Yes, in any setting where you have a large number of vulnerable people. So shelters and cooling centers are included. My listing was not exhaustive.
Got it. So we have another question about masks. Is the county concerned about unvaccinated customers who stay indoors without face coverings? There are some places where you can stay for long hours, even all day. Will those places need to require documentation?
So right now, the way that the guidelines are set up, especially for customers, it is left up to the business. I think a lot of businesses will still have the signs up to require masking, but as to how they verify vaccination status, that will vary. Or they might just say, well, there's no way we're going to be able to verify it, so we're still going to require masking for everybody who comes in. So we'll see how it turns out, especially after we get to know what the OSHA guidelines will say.
Got it. Yeah, and Trina's bringing up something about, folks who are immunocompromised and vaccinated, and there's been discussion about whether they should still wear masks. Would immunocompromised individuals include people with heart, kidney, or cancer in remission?
So I would say the answer to the first question is that immunosuppressed people should be wearing masks still. That's number one. Number two, I would not consider the groups that were noted there as immunosuppressed to the degree that we have data to support that the vaccine doesn't work as well. So let me try and say this in English and all the other languages that are being interpreted. The groups where we have data are patients with hematologic malignancies, so leukemias, lymphomas, and people who have had solid organ transplants and bone marrow transplants. And we know within those groups, about half of the people on average will not develop antibodies. So there is a significant percentage in those groups that will not be immune, and it would be safer for them to wear masks. I don't consider diabetics or heart disease or other kinds of things that degree of immunosuppression that should be associated with or cancer in remission in particular, that unless that is in remission because you're on an immunosuppressive medicine, those are not really the groups of people that I'm talking about. But the other thing I would say is that I don't think anyone's going to stop anybody from wearing a mask. And I think that if you are anxious, there's nothing really wrong with it. Most of us have gotten pretty darn used to having to stick these things on. We've been doing it for a year, and everyone has one around. So I wouldn't feel self-conscious if I decided to put one on just to play it safe. I think the groups that we're really focused on, and I think that's the same way I was talking about in the hospital, is that I think even after hospitals get back to somewhat normal where people are not routinely wearing masks, I think with those patients, with the organ transplant patients, with the BMTs, I'm going to still be wearing a mask every time I see them. I just think that we want to play it as safe as possible with those groups. I hope that actually started making some sense after a while.
Yes, I'd like to agree with what you've said, Dr. Cohen, that when you look at the guidance that the state has put out, they do state that for those, even if you're vaccinated, you can still continue to wear a mask. And I forgot to actually mention public transportation is one of those settings where masks are required. So if you're going on an airport and flying out, or if you're a train or bus, you'll still be required to wear a mask. And I did get the opportunity actually to go to a place where the state that has lifted the masking mandate. I will not let on which state that was, but it was interesting to see that a lot of the public places, such as stores, still had signs up saying that masks are still required, and a lot of people were complying. So my expectation is that even after June 15th, there will still be a lot of people who will choose, especially going into places where there's a lot of mixing between different groups, that people will continue to choose to wear masks because it gives you that additional level of support and comfort and protection.
Great. I was actually checking my pockets to see if I could find my mask, but remarkably, it's not in my pocket right now. But there are some more community members with, there's Dr. Cohen's mask, with some more questions about masks. And I think, some of their questions get to a deeper question of who sets the rules around which locations have to wear masks. So let's start with that.
So to start off, any workplace that is under the Cal OSHA regulations, they will have to follow whatever the Cal OSHA guidelines or regulations that are put out. Then for the rest of us, we will be going by the guidelines that CDPH has put out.
Got it. So workplaces, Cal OSHA, everything else, CDPH, and for folks that don't know, that's the state of California, the California Department of Public Health. Okay, great. And so there are two questions. One is someone who's really interested in libraries having masks, and then someone that's really interested in synagogues, temples, church, congregations with lots of folks inside having masks. So if you want to just talk about kind of, and there's probably other questions that'll pop up later of, specific areas where people want to advocate for masks being required. And so if you could just walk the community through what that looks like.
So the only additional guidance that is provided by CDPH is for mega events. So that's 5,000 plus for indoor events and 10,000 plus for outdoor events. So for indoor events, there will be a requirement that either you show vaccination status, that you're vaccinated, or that you have a negative test. And then for outdoor events, it will be highly recommended. But otherwise, apart from that, workplaces can still require people to wear masks. There are some settings, as we've mentioned, especially in places where there are large people or the number of people that are vulnerable, such as in jails, in homeless shelters, in schools, in hospitals and clinics. But otherwise, there is nothing that will stop an establishment from continuing to require masks for the people who access that facility.
Got it. Or not requiring masks. So it could kind of go either way. That leads into the last question we have here about masks so far, which is the mask guidelines allow self-attestation. Is that correct? Isn't that sufficient to allow customers inside? And they just want to comment, it seems dangerous to put businesses in the position to enforce masks.
I think that's been the difficulty that we have dealt with from the beginning, where even when we did have a stricter masking mandate, the onus was on the businesses to enforce it. And I think that will continue, partly because we do not have enough people in public health to be at every establishment to do the enforcement. So the businesses do have to do it. And the way that the CDPH or the state has set up their guidance for verifying vaccination status, they do state that self-attestation is acceptable. I'm from the feedback that I've received from some of the businesses, some of them state that they don't want to be in the business of trying to do the verification, so they will just continue to require masks, which is very okay.
Got it. All right, well, thank you all for your mask questions. They're great ones. We're gonna go ahead and pivot to another set of questions folks have about some kids that don't have access to the vaccine. So there's a couple questions around this. So if someone could outline what age group does not currently have access to a vaccine and what the timeline might look like for access.
So I can try to take that. So under age 12, the vaccine has not been approved yet for kids under age 12. And those studies are in progress, and I'm not sure how far along they are and how close they are to being available as EUAs like the other vaccines and for the other age groups. So they're in progress. There are studies with Moderna and with Pfizer in kids. There are still ongoing studies in the teenage group too, with the Novavax vaccine. But those studies are harder and harder to enroll because the younger people that want to get vaccinated can get the EUAs.
Got it. And so do we have any sense of a timeline of when the vaccine will be available?
Yeah, well, you know, this is, I'll be interested to hear what Dr. Kasirye has to say about this too. This is going to be a personal opinion. So I think one of the reasons that the vaccines could move out as quickly as they did in the beginning was because there were so many cases. And when you're trying to determine whether a vaccine works or not, you have to see how effective the vaccine is compared to a placebo group. And in order to get to what we call an endpoint quickly, you need a lot of patients in the placebo group to get COVID. That wasn't so hard 6 months ago, but now it is getting harder to do. And so I think the timeline may become a little bit longer. The pediatric studies are much smaller because they're just add-ons to what's already been done with adults. So maybe it'll be quicker than I think, but I would expect probably July at earliest. That's just a presumed educated guess. And so I am not obviously certain about that, but I think that's the thing. A lot of the other vaccine trials, for example, that we've worked on, they go on for a really long time because there are not that many cases, and it just takes time to be able to show that the vaccine really works. And that's what people want, right? You want something that's safe and that works.
I agree with you, though actually I'm thinking it will take a longer time than July, maybe sometime in the fall or even closer to the end of the year.
So a second part of this question is, who can be a part of the Kaiser COVID vaccine study in children under 12 years?
So I don't work for them, but for most clinical trials, there's usually a spot on one of their websites where you can get information as to who the contacts are to get in. I'm assuming that there are a limited number of exclusions, which would probably be those same group of immunosuppressed patients that we talked about earlier. In younger kids, some of those immunosuppressions are going to be genetic immunosuppression. But I think beyond that, it probably is anybody, unless they're already fully enrolled. I mean, that's the one reason that you might not be able to get in. But I would just go to the Kaiser Sacramento website and or the main Kaiser website. They should have a vaccine link, and you should be able to see how that works.
Great, thank you. Okay, let's go ahead and pivot sort of back to variants. There are a couple questions about the efficacy of the vaccines against the 6+ variants. Do those that are vaccinated need to be concerned about being protected against the variants, and will vaccine boosters become necessary?
So I think the answer to the second question is probably yes. Which is that we will probably end up needing boosters. The timing of which is not clear, and I'm maybe being a little bit optimistic today in my prior answer with pediatrics, and I'm going to be optimistic again. I don't think it's going to be an imminent thing that we're going to need boosters, because the evidence is that at least with the Pfizer and Moderna vaccine, there isn't as much information with the variants, but it does seem that they hold up, at least based on antibody concentrations, and so probably would be similarly effective. We do have some data with the J&J vaccine, and also with the not yet approved Novavax vaccine that did studies in South Africa. And the South African variant, I believe, is now considered beta, if I'm not mistaken. And so, and in those studies, the efficacy of the vaccine as far as preventing infections was less. So in the Novavax trial, it was about almost 90% with the non-variants and closer to 60% with the variants. But as far as the number of people who are being hospitalized and who have died, there's no evidence that the vaccines don't work in preventing that severe disease. So I think we're protected. I think it's, you know, it's a finer line to walk. And again, I will reemphasize what Dr. Kasirye mentioned earlier, which is basically that this is why we got to get people vaccinated, right? Because this virus, it mutates. It doesn't mutate that fast, right? If this was flu or something else, we would be seeing a lot more variants and a lot more variation within the variants. This doesn't change that fast. We can get this thing in a box if we really work at it. And I think the other thing that I am somewhat optimistic about, although the numbers are small compared to what the rest of the world needs, but I'm really pleased with the idea that the United States is starting to deliver vaccine elsewhere in the world where we need to contain the disease too, because these infections don't stop at the Pacific and Atlantic Ocean. Would be nice if it at least stopped at the Pacific Ocean.
And actually, I agree with you. I'm glad that we are looking at it and being able to ship vaccine to some other countries that still have very low vaccination rates. Oftentimes we are questioned about the effectiveness of the vaccine, and what I tell people is if you have any doubt, all you need to do is look at our long-term care facilities. There was a time when we had outbreaks in almost every single long-term care facility. And that's where we were. About 50% of our deaths in people over the age of 65 came from those long-term care facilities. And so there was a lot of concern. We were getting a lot of cases, but the way that the vaccination rollout was set up, that is a place where we started with the vaccination, especially the pharmacies that had a contract with the Centers for Disease Control. And so they were getting vaccine directly even before the counties got vaccine, and they started vaccinating. And actually, when we did an informal survey of many of the facilities in Sacramento, we were told that many of them were able to reach actually almost 100% vaccination. Some of them did reach 100% vaccination of their residents. And now when we look at our data, we're getting maybe 2 to 4 cases in the long-term care facilities. So if anybody has any questions about that, I think that's where they need to look. And also during the time Dr. Cohen mentioned, there was a time where our numbers were plateauing or actually started creeping up. If we still had the number of vulnerable people in the long-term care facilities that we had before, that is where we would have started seeing the huge surge, but the surge did not happen because those communities were protected. So if we are able to do that in the long-term care facilities, if we can achieve that for the community, even just getting to 70%, I think it could look great. When you look at places like the Bay Area counties that have been able to reach over 70% vaccination, their case rates are very low. Recently, I heard a report that San Francisco had 0 cases of COVID in their hospitals. I'd love to see that happen in Sacramento County. So we still have our work cut out for us, but it is achievable.
Awesome. So I will just name a comment here. So Trina says, I really appreciate the information that Dr. K and Dr. C present and the responses to our questions. I really appreciate these meetings. Well, we appreciate you for coming, Trina. So thanks for your feedback. All right, so the next question here is from Linda. Will Sac County be reviewing the cause of death on all death certificates to ensure that the death was due to COVID and not because they tested positive or for whatever reason, other reason for COVID at the time of death?
Yes, we do. Every single case, death actually is reported to Sacramento County. And for COVID, when we receive the death certificates, we actually also, especially if these are people who were hospitalized, we request the medical records and review them to ensure. So, and that's actually part of the reason why there is a delay in reporting the deaths, because when a death occurs, it takes time for the death certificate to be completed and sent to the county, and then an additional delay while we review, get medical records and verify before we actually put it on our dashboard. In addition to that, we upload all of that information into the state system, and the state also checks and reviews the information that we have provided in order to verify that this was indeed related to COVID and COVID complications. And also I want to point out, because that is something that we have seen on social media, hospitals and healthcare providers are not paid for death certificates. So they do not get any extra money for putting COVID-19 as a cause of death.
Well, sounds like a lot of steps in that process, a lot of checks in the system, which is great to hear. So let's head on to June 15th, because that is coming up. And one community member is wondering, after June 15th, will we still need to submit an events and gatherings application to the county?
No, there will not be any requirement to submit that request, but we are still available if you have questions about what you need to do, especially for those that are planning mega events.
Got it. And I know that the governor is keeping the state of emergency even after things open next week. As far as Sacramento County goes, are there plans if cases should happen to continue to rise in our county, even if the governor doesn't backtrack?
So the state of emergency or the health emergency is different from the health officer order. The health officer order is the tool or vehicle that we use to provide instructions to the businesses as well as individuals about what they needed to do. So that's where we had the stay at home, where we were telling people to stay home. That's where we were telling businesses that had restrictions, whether they could open or close, and what those restrictions were. So the health officer order is the one that is going to be retired come June 15th. But again, as we mentioned, COVID-19 will still be in existence after June 15th. We still need to monitor. We still have a lot of our staff doing vaccinations. And we still have a lot of community members who are still recovering from the impact of COVID-19. So we still need the health emergency declaration because that is the vehicle that we are able to use to get additional resources from the state, from the federal government, and also it allows us to accelerate some of the internal processes we have in the county. For example, getting a contract in place through the county is a long process. And during a health emergency, we are able to accelerate that process. And so that is what would help us to be able to get contracts in place for testing and also to get contracts in place to work with community-based agencies. So all of those will still be needed.
Got it. Yeah, you know, the difference between the health order and the state of emergency, all of it can get really confusing. So we appreciate you breaking that down. We have a question from Zuri around, is there any information on the vaccines being administered when people are arrested and jailed here in Sacramento? They have heard from community members that even though they have been vaccinated, they are forced to get vaccinated when arrested and are concerned about the safety of that.
So just want to make it clear that nobody is forced to get vaccinated, either those that are in jail or even those in the community. The process they have is that they have nurses who will go and each day will find out who is willing to get vaccinated, and then they will get them vaccinated. If possible, if somebody has been vaccinated before they get to the jail, if they're able to prove their vaccination status, that helps. But they can also just say they are not interested in getting vaccinated, and that will be honored. I don't have the numbers with me, but we've been steadily providing vaccine to the jails, and the uptake has been kind of a little less than what we would like to see. I think there was a lot of interest in the Johnson & Johnson because it's just one shot. But after it was paused, I think some people had some concerns. So we've had to do a lot of education to get people to understand that it is still safe for the majority of people, and that we are also offering the Moderna if people are still concerned about taking the Johnson & Johnson. So we will continue to provide that, but it is voluntary.
Got it. Audrey is wondering, are you finding any patients with breakthrough infections in the ICU?
we have had one that I'm aware of at UCD. This is sort of a phenomenon that has been looked at by CDC. And actually, if you go to the CDC website, I think they update relatively regularly the number of breakthrough cases that are either hospitalized or that die. And I think with the CDC data, it's not detailed enough to know patient by patient and whether people got infected between the first and second vaccine or otherwise, although they're defining this as people at least 2 weeks out of the second dose of vaccine is how they're defining breakthrough cases. I would point out, though, that again, those uncommon cases shouldn't change people's minds. In fact, when you look at it, I think right now there's a little over 500 people who have died after getting COVID, after getting vaccinated. That is out of 135 million vaccines that have been given. The percentage of that is got too many zeros in front of it for me to know what the number is, but it's something like 0.0004%. So it's really, really, really uncommon. And again, we don't know the data, so we don't know whether that was a transplant patient or somebody who was in the midst of chemotherapy for leukemia or something else. I think that the numbers shouldn't scare people off. And the fact that there are going to be these cases is, again, expected, not unexpected. So we've seen it. I wouldn't worry about it.
Okay, thanks, Dr. Cohen. And we have another community member who has some pretty specific questions about their wife who received the Moderna vaccine. She had an allergic reaction in her arm. 5 months later, there's a painful muscle knot where she received the shot. She still has limited mobility and pain. Is there any recommendation for how she can manage this?
Yeah, so we've seen this so-called Moderna arm that occurs typically after the second dose of vaccine and typically about a week after the second dose or first dose for that matter. It's an allergic reaction, and it is right. It typically is. It typically goes away on its own. I haven't heard or actually read about people that have had long-term problems as your wife has. My suspicion is that since it's so deep, there isn't going to be a heck of a lot that people can do about that. You know, back a long time ago, before we had good medications for HIV, some of our patients who had drug-resistant virus had to use these injections of a medication to try to keep them under somewhat of control. And they got these little knots at the site of every single shot they put in. We had people who taught them how to massage these things out and how to try to get this, because it's what your wife has is probably a localized inflammation that sort of just has to be worked through. I would talk to your regular doc and see if there's a way that they can get her to somebody who might be able to address that. That's the rash itself is not unusual. This long-term thing is is unusual, and I'm not sure I can do a better job of answering it.
All righty, thank you. Okay, so we have another question about COVID status as folks look at traveling. So H is wondering, at some point, will we be checking for COVID status of a travel destination like we check for weather or air quality to be prepared? And another community member is wondering if a copy of their COVID vaccine card will be acceptable when traveling, rather than taking the original.
Those are all good questions. And I think that before you travel, especially internationally, that you check what the requirements are, because my understanding is that for some countries, they're not even accepting the card. They are asking you to get a letter from the health department. So please check and make sure that you have the appropriate documentation. And then in some places, in addition to the vaccination card, they're still requiring that you have a negative test. So you need to know what the requirements are for your destination. And I think it is a good idea whenever you're traveling internationally to check the CDC website for anything that might be of concern, or any other vaccinations that might be required, or any infectious diseases that might be occurring in those areas, so that you can have the best preparation.
Awesome. So yes, if you're checking the weather, consider checking the COVID status as well. I think that's a really interesting way of thinking about it. So folks are wondering, in anticipation of June 15th and the state of emergency and the public health order, and kind of, understanding the difference between those things, if the state of emergency also helps provide protections from housing evictions as well as utility shutoffs, does that change come June 15th, or are those protections provided?
I think those protections were in a separate ordinance. So I think the best is to check the state website and find out what the protections are for eviction. I don't recall that they were part of the state of emergency itself.
Are we comfortable with the availability of tests for genetic variants?
I will say that I wish there was more. I think what my colleagues in Davis are doing when they're doing asymptomatic testing by saliva is they are testing every single positive to look for mutations. They don't do the entire genetic sequence, but they look for the mutations that are associated with the alpha, beta, gamma, delta variants. So they have a little bit of an idea what's going on, at least in Yolo County. I think nationally, I don't think this is a local issue. I think nationally, we have not really ramped up the testing to the degree that I think we should in a world leader like the United States. That's a very biased opinion. But I think if you look at what they're doing in Great Britain, it's a totally different deal. They are way ahead of what we're doing as far as sequencing.
Yes.
I don't mean to be critical, but I think it would be better. We'd know a lot more.
As Dr. Cohen has mentioned, we don't have the genetic sequencing being used very widely. Say, for example, in Sacramento County, we do not have the advantage of university that is being able to do the testing on every single positive sample. So we have to be selective about which cases we're able to send. We have to send our samples right now to the state, and the state has some criteria such as checking for people who already have a vaccination, and so considering the breakthrough cases, and then also for people who have severe disease. But otherwise, we're not doing it on every single sample. We're hoping that we will be able to get our system up and running at our public health lab, and that will help us to be able to do more of it. But definitely, in order to know, to have a good picture of what is happening real time with the variants, we should be doing more. And I wish we were able to do it for every single positive.
And while this doesn't directly correspond with the community member's question, I did want to use this as an opportunity to let the community know that we do have free PCR and, as of next week, antigen testing at our 13 community testing sites around Sacramento County. So I went and put the link of that in the chat, and you can walk up. You don't need an appointment. How soon, Linda's wondering how soon she can be vaccinated after getting COVID.
Yeah, we've been telling people to wait 3 months. That's a somewhat arbitrary number, but we know that the vaccine side effects are likely to be higher in patients that have already had COVID. I will, though, try to emphasize what you're asking, which is people who have had COVID should still get vaccinated. The intensity of the immune response is higher with the vaccine than it is with natural disease. The target antibodies in people who get natural disease is called the nucleocapsid, not the spike protein, which is really what's necessary to control the infection. And in addition, there appear to be some more non-specific responses with the vaccine that actually may improve the efficacy of the vaccine as well. This is stuff that just came out today. I haven't had a chance to read all the information in detail. So you still need to be vaccinated after you get infected. I would wait 3 months.
Will they do immunobridging? And I'm not sure who they is, but maybe we can fill in the gaps here. Will they do immunobridging studies or efficacy studies in kids?
Yeah, so it's sort of a little bit of both. So just to define immunobridging for people who haven't heard that term, it's saying the vaccine worked in this group when they had this much antibody. And so if we give vaccine to this group and they get that much antibody, we expect the responses to be the same. That's what immunobridging is. And so that's why the pediatric studies are smaller. I think the idea is there's a certain amount of that immunobridging, but there has to be some clinical data to support the efficacy. And so instead of enrolling 30,000 people in pediatric trials, they're enrolling 3,000. And so it's smaller. There's still some efficacy numbers, but there's also that whole concept of immunobridging that allows for the smaller studies.
And are there concerns yet about mRNA vaccines passing the blood-brain barrier?
No. So just to remind people who have probably heard this multiple times already, but the way that mRNA vaccines work is the mRNA is in a little piece of lipid, sort of a fatty globule, and that is injected into the muscle. And that fatty globule is actually the carrier for the mRNA, which then gets into those local muscle cells and then starts making spike protein, and then the mRNA is destroyed. So there's no circulating of anything except the spike proteins once they're released from the muscle cells. And most of that is not really in high amounts either. It's mostly local reaction that's going to engender your overall immune response. So there's no circulation in the bloodstream, so it's not going to cross the blood-brain barrier.
Awesome, thank you. I'm definitely learning a lot tonight, not things that I knew before. So such great questions that everybody has here, and I wanted to use this as an opportunity to invite folks to learn more. We have a vaccine ambassador training coming up on June 17th at 5:00 p.m. I put the Zoom link in the chat, so you're able to just join by clicking on that link there at that time. Again, this is June 17th at 5 p.m. We had about 100+ people at our vaccine ambassador training today, and it went really great. And if you're interested in becoming an ambassador in your community, we invite you to join that space. All right, so we have a question here about going back to masks. So Dr. K, I know you mentioned the different spaces where Cal OSHA might apply, whereas where folks look for guidance from CDPH or from the business. So Michelle is wondering about a specific area, about whether masks are going to be required in schools and daycares.
So right now, the guidance that we have is that masks will be required for children over the age of 2. But I think that they're still in the process of updating that. I think the state is waiting for the CDC to update their school guidance, and then the state will update the guidance as well. I'm hoping that guidance should come out soon, but from what we're told, they're targeting to make sure that it is available by fall. But right now, for schools that are in session or for those that have summer events, they still have to abide by the guidance that we have right now that still requires the masks. And the reason for that is that, as we've mentioned before, vaccinations are not available for children under the age of 12. And we know that COVID-19, even though it's much rarer in children, it does still occur and it can be severe as well. In addition, sometimes we have had situations where a child does get infected and then takes that, is able to transmit disease to family members. We know that some households have multi-generational, and so in that there might be relatives that are more vulnerable, such as those over the age of 65. So there is still some concern, and that is the reason for continuing to recommend that masks be used in those settings.
Got it. So this is a kind of a specific question about cases, but H is wondering, was there a post-Memorial Day increase in cases?
No, we did not see a post-Memorial Day increase. And again, I think that is another indication of the effectiveness of the vaccine. Because if you recall, with especially last year, every time we had a holiday or 1 to 2 weeks after that, we'd start seeing a surge in cases. It did not occur this time.
Susan is wondering if she can get some data around COVID, specifically for students ages 12 to 18 by zip code who have received at least one Pfizer shot. Is that data that can be provided?
No, we are not providing that information because it has to go through certain levels. And I think you asked about not cases, but you're asking about vaccinations, right?
Number of students who have received a
Yeah.
Pfizer shot.
Right. Yeah. Right now, the vaccination information that we're providing by zip code is total numbers.
Okay, so I am fully vaccinated. I believe I contracted COVID on a small scale. I tested negative. Could I have contracted a variant, but without being tested for the variant, I am testing negative?
So first off, you could have had a mild case of COVID and the test missed it because the tests are not 100% perfect. So that is possible. The DNA tests are better, or the RNA tests are better than the antigen tests, but they all miss a case here and there. And we've had circumstances where we've had to test people multiple times to ultimately find the infection. The way that the RNA tests are done is they target totally different areas in the virus than the spike protein, which is where most of these mutations have been looked at. Now, I don't know whether there could be misses somewhere else, but to the best of my knowledge, there's only one type of test that misses variants, and I don't think people are using that one anymore. And then every other one is not affected by variants.
A community member is wondering, what is the thought process when deciding requirements? It seems that 4,999 participants at an event have the potential to spread COVID as much as 5,000, where masks are then required. I don't understand.
You're right, but we have to make a cutoff somewhere. And in looking at the data, that was the cutoff. It's easier to remember 5,000 than 4,999. But you are right in that the dynamics by removing one person do not change. So these are just guidelines in terms of for the event, the people who are putting on the events to know what kind of guidelines they should follow.
What are the guidelines after June 15th for youth sports, especially indoors, for youth that are 13 or 12 years and older?
Yes, those guidelines are still being updated, so I can't really give you determination on what they will look like. I think that especially for outdoor activities, there will be a loosening of the requirements for masking. There's already a loosening of requirements for testing because of the reduction in the case rates that we have. So I think we're still waiting to see what the guidance will be for the masking, but I think there will be a loosening in the restrictions.
Okay, more to come. And will masks be required for children who attend events at businesses? Is it up to the business to verify the age?
It would be up to the business to verify the age. And again, it goes back to what we had said is that some businesses, when they look at the complexity of all of that, they just might decide that they will just require masks unless someone is under the age of 2, because that's easier to tell. But right now, the way that they're able to tell, especially where the price of a ticket differs based on age, they usually use self-attestation. So my impression is that that is what they will do in this situation as well.
Okay, we have 2 more questions, which is great because this is the amount of time we have left. So we have a question coming back to the death certificates. How confident is public health that the information on the death certificates is actually accurate? My husband died of COVID due to getting into the nursing home. And his original death certificate made no mention whatsoever of COVID. I rejected that, and the physician, redid the death certificate to make accurate mention. My confidence in data has been really undermined by my personal situation. What if I had not followed up on the situation and let the original death certificate stand?
That is understandable about your concern and I can understand your frustration with that. We do know that there are times when certain information will not be on a death certificate, but I think the providers do their best in terms of providing information, and we also do our best, especially with requiring records in certain situations. And that is why sometimes we have mentioned that there's probably an undercounting of the number of deaths that are related to COVID-19 because of situations like this. So our condolences to your loss, but I'm glad that you were able to advocate and make sure that the death certificate reflected the cause of death.
Does the county or state expect a surge in July after June 15th and any July 4th gatherings?
Sorry, you broke up a little bit. Could you repeat the question?
Absolutely. Does the county or state expect a surge in July after June 15th and any 4th of July gatherings?
I'm hoping that we will not see any surge. As we mentioned, we did not see a surge following Memorial Day weekend, and we are continuing to vaccinate, especially going to those communities that have lower vaccination rates. So our hope is that we are definitely out of the woods, though this is not over yet because we are still getting cases. But I think we are all very hopeful that we will not see the surge again unless something major happens, such as some variant that is not protected by the vaccines that we're getting. But otherwise, I think that we'll quite probably continue to see some cases until we're able to get enough people vaccinated to completely get this under control.
Okay. And Susan had a clarifying question about the data for students. Does the data exist about students ages 12 through 18 with at least 1 shot of Pfizer? Olivia seemed to indicate yes, but it's not being shared.
We do not have that information right now. As I said, the data that we have provides only the totals, because it will take a while before, in order to be able to get that information by age, you would need to look at other fields that include the date of birth, and that always requires additional cleaning. So right now we just have the data that gives us the totals. Also to point out that the databases that we are using are actually state databases. So we have to wait until the state does the cleanup of the data before that information is available to us.
Great. And I will end us off with a thank you from Holly. Holly says, thank you, Dr. C, Dr. K, Liz, the ASL interpreters, and the language interpreters. You are the marathon heroes in our county as the liaison for dispelling rumors and bringing hope with your messaging work. Thank you, Holly. We appreciate you as well.
Thank you.
All right. Well, any last words? We'll start with Dr. K and then end with Dr. Cohen.
Well, I just want to thank you again for hanging in with us. I know we started this and we weren't even sure how many of these we would do, but we're very pleased to see the continuing interest in having these forums, and the questions are very thoughtful. And so we appreciate that. And we are also hoping that the information that we provide is helpful. Since we are getting to June 15th, where the businesses are going to open up, we are thinking of reducing the frequency of these forums. So starting in July, we will be having them once a month, and Liz will put that information out so that you're able to know which Thursday we will have these forums. But thank you again for your attention and for your very thoughtful questions.
Yeah, I don't have a lot to add. I appreciate that I get invited to participate, because I think that this has been a very helpful thing to the community. And I am always impressed with the quality of the questions and the interest that has maintained through the course of these programs. So we thank the Sacramento community, and we'll keep moving forward.
All righty. Well, that's all for tonight, folks. We appreciate you. We hope you have a fabulous rest of your Thursdays, and we will see you again in 2 weeks. And then, as Dr. Kasirye mentioned, we'll move to a monthly cadence after that. Thank you.